谢谢杨院长。Next, we are very happy to have Professor Orts from the University of Texas Southwestern Medical Center to give us a speech about the PET tracers other than FDG in the immunotherapy. Please, Professor Orts.
好，理事长
Thank
，Thank
you. Are
you.
you able to hear me now?
We will introduce you. 理事，各位会
I
员
heard her introduce me. Okay. Yeah.
Okay. Good morning, ladies and gentlemen. This symposium has invited a distinguished international scholar to address this issue of immunotherapy. Dr. Orhan is professor of radiology and the chief of nuclear medicine in University of Texas Southwestern Medical Center. His clinic interests include nuclear medicine, radiology, thyroid and musculoskeletal disease, cancer and cancer imaging, with a particular interest in neuroendocrine malignancies. His research results in many publications, including especially SPECT and CT to stage the severity of food infections in people with diabetes. The topic of this talk is use of PET image other than FDG in immunotherapy. Let's welcome to him.
Thank you. Are you able to see my slides?
Not yet.
Okay. According to me, I'm sharing. Let's see. How about now?
Yes.
Let's begin now.
Okay. Are you seeing my title slide?
Yes.
Okay, great. Well, first of all, thank you for having me. And I took the liberty to modify the talk just a little bit to focus more on what we're doing in this area of immunotherapy. So my modified titles use of PET imaging other than FDG in immunotherapy, with an emphasis on IPET and immune checkpoint inhibitor imaging and renal cell carcinoma. So this slide gives you just a very high-level overview of immunotherapy. In the talk before me, you heard great detail and review of the literature in all of these areas. But from my point of view, I think of immunotherapy as several domains: monoclonal antibodies, engineered T cells, immune checkpoint inhibitors, cytokines, cancer vaccines, and immunomodulators. And as I said, we're going to spend most of our time in looking at how can we predict efficacy in this domain. So just by way of overview, immuno-PET can be defined as PET imaging performed with radio-labeled immunoconjugates or engineered lymphocytes. It's enabled by, obviously, radioisotopes that have different half-lives. The benefit of it, of course, is it combines the specificity and affinity of the antibody-antigen interaction together with the sensitivity of PET to allow us to do whole body, quantitative, non-invasive and longitudinal imaging. You need, of course, an antibody, engineered fragments, and positron emitters, and the field currently focuses on gallium-68 and 64 and zirconium-89, though there are some recent publications with small molecules using gallium-68, which I won't discuss. And then, of course, for any clinical trial, you need cancer patients and biological and clinical support. This schematic to the right simply shows you all of the various engineered forms. We'll have more to say about this, starting with the classic heavy chain and 2 light chain antibodies in various fragments, FAB2, mini bodies, diabodies, and so on. In general, the smaller you get, the faster it's cleared from the body and renally cleared, as opposed to hepatic clearance. Now, I don't expect you to take in this whole table, but for the next few slides, I am going to give you my way of overviewing the literature simply by looking at studies in summary form, tabular form, that comprise the main components, whether it's targets, antibodies, and radionuclides. And what you can see is every cancer nearly has been leveraged with specific targets for immuno-PET. And these are the PET probes. For example, we're interested in renal cell cancer, and you've heard, and you'll hear more about PD-L1, and we're leveraging zirconium-89 conjugated to, or chelated to DFO and conjugated to atezolizumab, excuse my pronunciation. Now, I don't have melanoma here, but you've heard a lot about melanoma in the previous talk. These are just more cancers and their common targets, and then the immunotracers. And again, you can see PD-L1 being targeted even in head and neck cancers. Now, this slide focuses on the vectors or antibodies associated with this, but displaying the information in a little different form, going all the way from your intact antibody to small affibodies. And you can see, for the most part, with the exception of the intact antibody, which we produce by immunization, modern IPAT and antibody generation takes advantage of the ability to engineer these. Now, as imagers, we really want to focus in on what are the sizes of these molecules, going all the way from 150 kilodaltons to as small as 60 kilodaltons. And then we want to pay attention to the tumor penetration, ranging from days to less than an hour, and how it clears, because this will help us interpret the images as well as match our radionuclide with the expected biological half-life of these. Now, this is a long, well, somewhat abbreviated list of radionuclides that have been used in immuno-PET. As I said before, I-124 is 4.2 days it's used, but it doesn't have that great a beta emission, and it has high energies. And for us who have to interpret these images, when you see these relatively high energies, you know you can expect imaging blur. Now, zirconium-89 is a favorite of ours. It has a 3.3 day half-life, which makes it amenable for using intact antibodies. It has a slightly higher beta emission ratio than I-124, but again, it's high energy. Copper-64 is used heavily. We use it, but I won't show you any data here. It has a 13-hour half-life, and it's good for imaging, say, for example, FAB2 fragments or even multi-time point imaging. But again, this is only 18%, somewhat better energy levels. And most of these are produced by cyclotrons. And we certainly produce zirconium and can produce copper 64. Now, I wanted to, since this is a talk that's supposed to delve in immunotherapy, I did want to point out to you how IPET is reported in many clinical trials that utilize immunotherapy on clinicaltrials.gov. The majority of those are in predicting the response to therapy. Okay, whether it's targeting PD-L1, CD8 on T cells, or a receptor, you are aiming to predict whether whatever therapy you are imaging or intending to use will be beneficial because your target is there. Now let's step back a moment and look at this schematically. Again, as I as a radiologist and nuclear medicine physician, I like to think of things conceptually. So when we think of the tumor and immune cell interaction, there are a lot of these interactions in the microenvironment. And this schematic shows a tumor cell, a T cell, macrophage, and dendritic cell. And as you can see, this T cell is interacting through a lot of these ways. You heard about the MHC interactions with the T cell, or PD-1 interacting with PDL2, or our favorite interaction, PD-1 expressed on the T cell and PDL1 expressed on the tumor cell. And these interactions by the tumor cell with the immune cell allows that tumor cell to trick the immune cell so as not to attack it. And again, the two common ones are PD-1 and PDL1, and this is just a higher resolution of that interaction, but together with an inhibitor. So if you were to put treat this patient with a say PD-1 inhibitor or even a PD-L1 inhibitor that blocked this interaction, you then prevent the tumor cell from tricking, so to speak, this tumor cell not to kill it. And that is the basis for the research project I'm going to describe to you. So this slide just sort of summarizes again some of the utility of targeted imaging to characterize and predict immune-related tumor responses and progression, to detect and monitor immune-related events, non-invasive decision support, and as an imaging biomarker. I think all of us know how rough this immuno-oncology can be on patients, and we want to be able to predict as much as we can whether a patient would benefit before we subject them to that. And in my mind, at least the projects I'm involved in, that's a main benefit of this immuno-PET imaging. So how do we make zirconium-89 atezolizumab? Well, Zhenkai Sun, who's our director of our cyclotron and radiochemistry program, his group first derivatized this antibody that we got from the oncology pharmacy, and then attached the chelator, DFO, onto it, and then through a standard chemical reaction in their lab, we're able to chelate the zirconium-89. And this was done manually for the first few tries, but now they fully automated this, and these schematics are just designed to show you all of the tools required, the assembly of the purification scheme, and now it's all automated inside our cyclotron and hot cell. So all of this is now automated, minimizing the exposure. So our group have proven you can make this and make it in high radiochemical purity. So then you turn to preclinical models to demonstrate that you can effectively target. This top row shows you a series of mice bearing patient-derived xenografts of varying expression, high or low, of PD-L1. This line tells you the percentage on a microscopic level, and this is staining. The brown is specific staining for PD-L1, and this is just the H&E. And this shows you the comparison of the patient's tumor sample to that PD-L1. And this particular XP955, you see there's very good correlation. And this is just the patient H&E. So we felt pretty good that we could target this with the label conjugated antibody. And this slide just shows you again the nice correlation, positive correlation of PD-L1 expression with the tumor to muscle ratio. And then if we look at the distribution of our signal, this time expressed as percent injected dose per gram, you can see that the xenograph with the high expression has a right shift of these pixels. Again, it's a heterogeneous distribution, and you'll see that on the human images I'll show you in a moment. But suffice it to say, we were again encouraged that the high expressor had a mean value higher than the lower expressor. So all of this data, taking these patient-derived xenografts, putting them in mice, doing the preclinical experiments, and this graph of the PD-L1 expression versus the whole body PET went into our application to the FDA for an IND. And this is just a copy of the letter for our phase 2 study, which is a pilot study of zirconium-89 DFO atezolizumab Immuno PET in patients with locally advanced or metastatic renal cell carcinoma. And for the rest of the talk, I'm going to show you some data from that talk, and some of the challenges we faced. So our study overview, our hypothesis was that non-invasive imaging of PD-L1 expression will correlate with the histologic expression as determined by immunohistochemistry, and allow us to select patients that may respond. To date, we have up to about 19 patients now, but at the time of this slide, it was 18. And we are studying patients that have localized or metastatic renal cell carcinoma with metastatic, or patients only with metastatic renal cell carcinoma. And the aim for these patients in group 2 is to look at response to treatment, and this group 1 is correlation with the immunohistochemistry. And to the left here, I'm just showing you the flow diagram of what we do. Again, we identify whether they're eligible, we inject, and we bring these patients back a week later because these are intact antibodies. And then if it's positive, we do the treatment, and we follow up with standard of care imaging, for example, CT scan. We may apply RECIST criteria to see if the tumor responded by standard criteria. If the RCC it recurs by surgery or there's progression, on these standard images, we may repeat that imaging. And of course, this was our first patient. And you see this, here's a right temporal lobe lesion on MRI. Here's the corresponding immuno-PET imaging, and it just looks great. You notice you see this lesion very well contrast enhanced with a lot of edema around it. And that's very important if you're going to leverage this technology and this particular antibody and radioisotope, you need to know that. The masked images show this kind of central intensity and this halo. Again, that gets to be very important. The tumor was excised. We were able to do H&E, PD-L1, IHC, and you don't see a whole lot of intense staining. However, if you do autoradiography, you see this heterogeneous distribution. The darker the signal, of course, the more the antibody accumulation. Okay, so keep that in mind. Heterogeneity is what we have observed. And while I showed you that beautiful image, the first set of images that we got looked more commonly like this. This is a image whole body MIP obtained on a certain manufacturer's scanner and reconstructed with the standard OSEM and time of flight methods. And you can see the liver, the spleen. Not surprisingly, you're going to have a lot of cells that are PD-L1 positive in the spleen. Then you have the kidney here. Then the right kidney with a mass that you can't very well make out. And I'm intentionally showing you this because in the literature, you see these very nice images. And there was a very famous Nature Medicine paper that showed these beautiful images. And that's just not what you see most commonly when you do that. And this is a lung metastasis, and this is a transaxial image showing you all of the noise and the heterogeneity in the uptake. So we start to ask ourselves, okay, how can we deal with this? Okay, we can look at this with conventional imaging metrics, whole tumor histogram base to characterize both interlesional and intralesional heterogeneity, and then do correlation. Of course, we would do conventional imaging metrics such as SUV and tumor to blood ratios. And this is another display of a patient who's had a right nephrectomy, who had some lung nodules that you see my arrows pointing to. But I'm showing you this to show you a violin plot of how even within standard organs like the liver, how you can have heterogeneity across it. Again, when you're using standardized, the standard OSEM and time of flight imaging. Again, the spleen is higher. You see a lot of heterogeneity across the blood pool. Muscle has the least activity, and we use that as a reference region, but it too has some heterogeneity. Well, on to some real images. This is a patient who had renal cell carcinoma, status post a contrast enhanced CT, has an adrenal met, this very heterogeneous liver metastasis, and then the primary lesion here. Okay, and now on this pseudo-colored iPad image, you can see these more focal areas around the periphery with central lobe activity, but the adrenal lesion is very intense, and you hardly see much in the primary. And this is a pattern we've seen quite a lot. And those of you who may leverage this technique for renal cell cancer projects, you should be aware that there's often a lot of necrosis in these metastases and a lot of perilesional fluid. So we ask ourselves, beyond SUV, how can we then begin to get information from these images that might better characterize the antibody distribution, which again, we hope will then tell the oncologist whether this patient's lesion is likely to respond. So looking at this distribution, my mind went to two characteristics, skewness and kurtosis. And you can describe skewness as positive or negative, right shift or left shift. Again, the peak being beyond the mean or deviating from a normal distribution. And then kurtosis, that describes, again, compared to a normal distribution, how that peak is spread out around the median value. Okay, so a lower kurtosis corresponds to this broad, flat peak, and then the skewness defines the asymmetry of the distribution. Distribution that appears more stretched out or left shifted has a negative skewness, while it's right shifted has positive skewness. And this is what we started to see. Look how more symmetric that adrenal lesion is. We just picked the liver lesion. You almost think that there are at least two peaks on this liver lesion, and the kidney lesion is shifted to the right. And then these are just plots of the standard SUV max. And as you might expect, this adrenal lesion was the highest. But look how high the liver lesion is. That doesn't tell you much because that may be only imaging a part of it. Tumor to blood ratios are calculated here. And then your skewness and kurtosis. We have both negative and positive skewness and mostly negative kurtosis to date. Now, this is a patient that's very interesting. I want to call your attention again to the primary and to this rib lesion. You can see this rib lesion again had heterogeneity. The primary renal lesion to the eye mostly had peripheral activity and some central low activity. If we had an MRI, it probably would be negative. And you can again see this very multi-peak histogram, whereas the rib lesion is shifted more to the left and has two peaks. Okay, again, you can see that skewness is very high. Now, after this patient was treated with immunotherapy, well, look at what happened to this rib lesion. Okay, it had a good tumor to back blood ratio, but very high skewness, relatively speaking, and negative kurtosis. The renal lesion itself didn't respond, but the rib lesion responded very well. And this is a pattern that we've seen at least 3 times. So what we can summarize so far is that of the 5 patients, we found that when this group 1, these are patients with primary and metastatic lesions, the tumor to blood ratios appeared above that 25th percentile in the Violin plot. Whereas if you look at group 2, again, we had 3 primary and 28 metastatic responders. And again, this is by your RECIST criteria. Their values tended to be over the 75th percentile, had high skew values and low kurtosis values. And this is just a demonstration of your receiver operating curve for skewness, kurtosis, and tumor to blood ratio. So to date, despite our intuition that these kurtosis and skewness, which would describe the distribution of that activity across the lesion, would be better predictors. To date, the area under the curve is actually higher in the tumor to blood ratio. So, none of them have that great sensitivity, but the specificity so far has been about equal, though slightly higher in kurtosis. So we continue to develop this again, and tumor to blood ratio might be better than some of these that characterize the distribution of pixels as we had thought. So this is just a summary of what I said, combining some of the conventional metrics and some of these distribution metrics, we hope may give a better prediction of who will a lesion-based response to immunotherapy. Again, thinking back about that rib lesion versus the primary kidney lesion. All right, so I want to now switch to the next problem area that we have seen, and that's noise. I don't know what kind of scanners or reconstruction algorithms you have in your practice, but when we originally started this project, we had OSEM and your standard OSEM plus time of flight. And this is just that same MIP image I showed you before, but showing you the noise with it. And this is a general problem with zirconium. Unless you have proprietary software that can, use an advanced technique, do noise suppression, but it's not available across all PET imaging platforms. And so there's an unmet need to utilize open source software for this. The proprietary product is known as QClear and is offered by GE. I apologize, this should be something called a beta value here. And this is a parameter that you can adjust in GE software to produce noise suppression and image smoothing. And this general area is known as Bayesian penalized likelihood algorithms. Now, when we started the project, we didn't have this OACM, but we did have something called non-local means-based denoising. And you can set various filter strengths, windows, and kernels around that, and worked a lot with a physicist here, Spencer Bowen, who helped us with this. But this is a paper that my resident, Jen Chi, who's in the audience, chose from the literature, just showing the effect of increasing the beta. If you start with a low beta, you see how noisy that is. As you increase beta, you suppress the noise, and this lung and rib lesion, they get more obvious, and as does your lymph nodes. This also, I want to call your attention again, if you do this intact antibody, look how long the blood pool can last. This is your sagittal and transverse sinus activity still in the blood pool 7 days later. And these investigators go all the way up to a beta value of 7,200. In our institution, we use 7,500. After the project started, we did get a GE scanner, and that's what we're using now. To my surprise, their OSEM images look very nice. Frankly, I haven't been able to reproduce this. So what is the benefit of non-local means? It's verbally describing, it takes advantage of redundant information that is present in an image. And the algorithm compares various regions in the image to similarity, for similarity, and it combines those based on some quantification of that similarity. Okay, it's a part of these edge preserving denoising approaches. It preserves significant PET signal over the underlying structures. And in the best of worlds, it effectively discriminates genuine signal from unwanted signal. So faced with this, I'll go faster now because we're running out of time. We designed a study after we were about halfway into the project in which we looked at these various semantic features, the intensity of the activity, the shape, the size, margin, and distribution, and assigned a certain scale rating to all of these. Say, for example, 1 if there was no uptake, you assign a score of 1 for intensity, 5 if there was very great uptake, or a distribution if you don't see a lesion, or you have central or peripheral intensity greater than the middle, you assign these 2 or 3, and rarely, in our experience, you assign a level of 4 if it's homogeneous, and 5 if it's very irregular. And this table just summarizes the radiologist's evaluation of those images, okay, looking at them qualitatively from scoring. And the biggest impact on this non-local means denoising has to do with the shape and the margin. Both of those were statistically significant. When it came to quantitative assessment, we saw a negative effect actually on the liver SUV mean. It went down. So did our tumor SUV max, and the tumor to blood ratio all went significantly down. So while you have noise suppression, you actually lose signal. And again, this is that same patient, your original reconstruction. The noise suppression, at least in our hands, it seems to work better in the chest. And there's the lesion on the non-contrast CT. So to summarize what I presented to you today on a research project, the zirconium-89 atezo, it does enable iPET imaging of PD-L1 in renal cell cancer. And as you saw from the clinicaltrials.gov information, other cancers as well. But there are challenges to realizing the full potential of this tracer. Most notably, image noise and the distribution of the radio-labeled antibody in that tumor environment. Of course, if you're fortunate and you have scanners with this commercial proprietary software, then you may be able to minimize this problem. Or you may have access to medical physicists or imaging scientists who can help you with open source software to mitigate the effects of image noise. And we believe, and this is what we're working on, advanced imaging analysis together with conventional metrics to see if we can better predict who will respond to anti-PD-L1 immune checkpoint inhibitors or not. I'll just skip over this for the sake of time. One thing I didn't tell you, if you begin to do this, one of the things we found out, again, kind of the hard way, is that it's very beneficial to inject cold antibody with that, to either saturate circulating antigen, fill these fluid spaces I've told you about, or the non-specific entrapment you see in the spleen. Right now, we're co-injecting 10 milligrams of that. Some people go up to 20 to 50. It depends on what you are saying. And the image quality certainly goes up. So with that, I just want to acknowledge the financial support. This, what I've shown you, has been basically a kind of a 3 or 4 year journey. I think Jimmy was in our group when we started this project, and he first made the contact of me with the leaders of the society, and thankful to him for doing that. But all of these funding efforts have allowed us to do this multi-year project to get here. And I want to thank our collaborators, especially I didn't put the most up-to-date slide. My resident, Jen Chi, who's in the audience now, she and I have done a lot of work on this research project. We, of course, have members of the medical oncology team, Dr. Chen and Dr. Brugarolas, and then my long-term collaborator, Dr. Sun. We have worked together for a long time. And then Spencer Bowen, who helped us with that. So with that, I just thank you for your attention and for giving me the opportunity to tell you about zirconium-89 atezo and RCC, the benefits, the challenges, and limitations. Thank you.
Okay, Dr. Thanks for your excellent presentation. The floor is open for discussion. We welcome to your questions and comments.
Okay. Will the questions be live or put in a chat or?
Any question?
Professor Arts, thank you for your excellent speech. I just wonder, the zirconia is developed from your cyclotron, or you purchase from a commercial center?
No, we have the ability to produce it locally. Yeah. So we have a good benefit of that. Now, copper 64 we do get commercially, but zirconium 89 is produced in house.
Okay. So
And I'm happy I'm happy to connect Zhenkai to anyone who may want to begin production there. We have a G trace cyclotron, yeah.
Okay. And how about the labeling of your antibody? The process is complicated, but I think you said you have automatic.
Yeah, his group has automated it now, and I wouldn't venture to be able to describe that to you. I used to be every day in the lab and able to do those, but these days I'm spending more time interpreting images than doing the basic science. So I would be happy to put anyone in touch with him who wants to be able to learn the steps involved in that.
Because we have interest in developing this immunoPET tracer. If in the future, if there is an opportunity, maybe we can contact with you and
Sure, even visit our group.
Thank you very
We
much.
have visitors. Yeah, we have visitors come and spend time with us. And we send our team members sometimes to other sites as well to learn new techniques.
Okay.
Definitely open to visiting.
Okay. Yeah. Thank you very much. And we will
my pleasure. And again, you know, this was mostly a research talk, but I thought it's a way to kind of give you what we're doing at the front end today. Okay.
Thank you. Thank you.
All right. Thank you very much. Enjoy the rest of the meeting.
Okay. A question from Dr.
Thank you. And I would like to ask a question. And how about other tracers such as radial iodine or India 111 or Gradient 67 for gamma camera and SPECT?
Right. Yes. So, you know, that's a very good question. And you have, you know, anticipated something I'm very interested in. We in fact do have immunospect paper published maybe last year or so, actually using a copper analog. But there our idea was it was copper 67 to use as a theranostic. So copper 67 you can image for the gamma with the gamma camera, but it also is therapeutic. So that's in our preclinical models so far what we have done. In preparation for that on the clinical side, we're beginning to calibrate our cameras so that we can get quantitative data from that. We have somewhat shied away from the iodination of antibodies because dehalogenation, at least in my hands when I was still working in the lab every day, in vivo dehalogenation tended to be a problem. Indium will work, but we place a lot more emphasis on the PET, so I kind of shifted away from that, but we are going back to immunospect And the idea I like about that is the potential to do dual target imaging. So right now our medical physics team, for example, we are designing phantom experiments to optimize photo peaks of some of the radionuclides that you mentioned, to be able to simultaneously image two antigens that are being targeted by that. So I think definitely immunospect has a future, and with the quantitation available now, either through digital spect or the XSpect platform from one of the vendors, I think it has a bright future, and I hope to be a part of that bright future.
Okay, thanks for your answer. We have running short of time. It's time for us to close this session. Let's move on to next talk.